Bueno, muy buenos días, colegas invitados. Good morning, dear colleagues and guests. Bienvenidos al seminario virtual abordando la salud de los hombres y las masculinidades.
Welcome to this virtual seminar on addressing men's health.
My name is Carolina Holmes. I am the advisor of the Healthy Life Course Integrated Approach at PAHO, and it's my pleasure to co-share this interesting webinar with my colleagues Jessie Schott-Ain from PAHO and Professor Derek Griffith from the Georgetown University. The webinar is co-organized by the Global Action on Men's Health, the Center of Men's Health Equity from Georgetown University, and PAHO. Today, we have a selected and experienced panelists that will share their knowledge and expertise in the area of men's health and masculinities across the life course, as well as regional and country perspective. Before we start, I want to share with you some instructions. Brenda, can I ask you to share the instructions, please? Today, we will have a simultaneous translation. Continuing in the meeting implies consent for recording. To access the language of your preference, please go to the bottom of your screen. There you will find an icon with a globe shape. If you click there, you will see two options. If you click again in the language of your preference, you will have access to it. The chat has been enabled so you can share relevant information and materials. During the questions and answer sections, you can use the chat to post your questions or experiences. Thank you, Brenda. You can remove the slides. Please let me take a few minutes to introduce the first three set of speakers who will provide the opening remarks. The opening remarks will be conducted by PAHO's Deputy Director, Marilu Valdez, followed by Peter Baker, Director of the Global Action on Men's Health. We have also a special guest, the Honorable Minister of Health of Guyana, Dr. Frank Anthony, who will provide the opening statement. Now, I would like to invite our Deputy Director to provide the opening remarks. Fernando, please.
Distinguished guests, dear colleagues, ladies and gentlemen, it gives me great pleasure to welcome you to this virtual event, Addressing Men's Health and Masculinities in the Americas, a public health imperative. I wish to express my appreciation to the Global Action on Men's Health, the Center of Men's Health Equity, Georgetown University, and my PAHO colleagues for co-organizing this important event. I would also like to recognize country representatives and experts who are joining today to share their expertise and experiences on this topic for our member states. Dear colleagues, in the region of the Americas, the area of men's health and masculinities has generated much interest, not only in response to a greater focus on women's health, but due to the differences between the trends and trajectories of men's and women's health. These differences begin early in life and persist throughout the life course to advanced ages. The way men and boys think about and project an image of themselves as men and how they respond to gendered social norms and pressures has been identified as an important part of the explanation for unhealthy behaviors and premature death in men across the life course. The evidence shows that statistically, men are more likely than women to die before the age of 70 and have a higher mortality rate across the life course. The differences in mortality between males and females peak during adolescence and early adulthood when gender socialization becomes more pronounced, with male death rates increasing substantially, primarily due to violent causes and suicide. We also see that men are having higher mortality rates from COVID-19, which may be linked with higher incidence of cardiovascular disease, hypertension, type 2 diabetes, chronic obstructive pulmonary disease, and tobacco use in males. Other factors also help to explain this trend. Men are more vulnerable than women to some infections due to underlying biological causes, including immunological, hormonal, and genetic differences. Men also tend to have poorer general health and reduced access to health care. These differences have contributed to a sex gap in life expectancy. Life expectancy at birth in men is on the average 5 years less than in women, and it is estimated that this gap will increase over the next 15 years. This gap is also observed in the geriatric life expectancy. Even though life expectancy at age 60 and 80 years old for men has increased in the last decade, there is still a gap of 3 and 2 years between men and women, respectively. For the Pan American Health Organization, addressing men's health and masculinities is a priority to advance universal health and the gender equality agenda. Distinguishing women and men's health needs will lead to a major improvement in health, since both are different in many aspects and therefore require different health approaches, but also their health behaviors influence each other. These improvements in health would not only benefit each of these groups, but there would be a shared health improvement for men, women, their families and communities, and across generations. Today's webinar will stimulate the discussion on many of these issues and will open the door to questions that need our attention. These include, what can actually be done? How can the Sustainable Development Goals and universal health coverage be delivered if men are left behind? We at PAHO are convinced that efforts to improve public health must include attention to both men and women's health, reducing gender equality, and improving well-being across the life course. I hope you have an engaging virtual event and a deep discussion that will spark efforts for identifying and implementing effective solutions in men's health and masculinities across our region. We need to work together to advance universal health and the gender equality agenda. My sincere thanks to all who are here today and have supported this virtual event. I look forward to learning about your discussions. Thank you and good luck.
Okay, so after this, our Deputy Director words, I would like to pass the floor to Peter Baker. Peter, the microphone is yours.
Thank you very much, and hello everybody. On behalf of Global Action on Men's Health, I'd like to welcome you to this very important webinar. I'd also like to thank PAHO and the Center for Men's Health Equity at Georgetown University for the opportunity to collaborate on this event. For those of you who don't know Global Action on Men's Health, we're an international charity based in the United Kingdom. Our role is to push men's health up global and national health agendas and to make sure that men's health, alongside women's health, is taken fully into account in research, policy, and practice. Why do we do this? It's quite simply because men's health is unnecessarily poor, not only in the Americas, but around the world. Men have shorter lives than women, especially those men who are disadvantaged because of their income, race, gender identity, sexuality, and many other factors. The experience of COVID, which has so far caused around 9 million excess deaths in men worldwide, and that's around 60% of all deaths, has revealed very clearly some of the main problems in men's health. The greater incidence of those underlying conditions, such as high blood pressure and lung disease, that lead to worse COVID outcomes. Lower compliance with prevention guidance, in this case including vaccination, especially in the younger adult age groups. And there's been an almost total lack of male-targeted interventions from governments and health services. But we know what needs to be done. We need health policies that take men into account, health services that engage men more effectively, and more research into how we can deliver the kinds of programs that work for men. These initiatives are now beginning to happen, but on a scale that is too slow and limited. However, I'm very hopeful that this fantastic webinar will kickstart a new and more urgent approach to men's health in the American region. So thank you everyone for coming, and I hope you will find the next 90 minutes both interesting and inspiring. Thank you very much.
Thank you so much, Peter, for your words and for highlighting the importance of advancing the men's health agenda in the region. Now, I would like to invite Your Excellency, the Minister of Health of Guyana, Dr. Frank Anthony. Dr. Frank Anthony, the floor is yours.
Thank you very much. Thank you very much for having me at this webinar. I want to thank PAHO and the Global Action on Men's Health for co-organizing this event. I'm sure that in the next 90 minutes, we'll have a very intense discussion, and we'll leave here much richer than we came. I think it's very topical. The area of men's health have been very neglected in most countries. We tend to focus broadly on health, but without disaggregating the data and looking at how we can strategize and have programs, especially targeting men. We have heard from the previous two speakers about the mortality among men, morbidity among men, the types of diseases that affect men. And when we look across the life cycle, the challenges that we have. Yet for many countries in the region, we do not have programs that would address these types of challenges that we have along the life course. I think we need to change that. And it is good if we can develop holistic policies at the regional level, and then help countries to develop particular national policies so that we can improve men's health. When we look at infectious diseases, as was mentioned, COVID has had a great impact on mortality, but also the more traditional infectious diseases, HIV, malaria, especially in some of the interior areas of our country, where malaria has been very prevalent and affects predominantly men who go out to do prospecting for gold. So this is an area that we have to look at. Compliance with taking treatment. A lot of men who have been infected, they don't want to take their meds, especially if it's for a prolonged period. And then when we look at the chronic non-communicable diseases, we have seen that amongst men, cardiovascular diseases, cancers, kidney diseases predominantly affect this age group. And of course, we also have mental health illnesses. We have seen all of this in Guyana, and we are working to see what we can do to address these issues. More recently, we have established a men's health unit in the Ministry of Health, and we have started to roll out programs that can address this. But we have very limited, or we are piloting some of these things. And if we're going to have an impact, we really need to do it at scale. And I'm sure that with the experiences and practices that would be shared here today, we will be able to learn more about what we can do to improve men's health in this region. So I look forward to the discussion, and thank you once again for inviting me. Thank you so much.
Thank you so much, Dr. Frank Anthony, for your open statement and for describing the situation in Guyana and the effort conducted in your country, and of course for supporting this important topic for countries in the region and the Caribbean. So I'm going to switch to Spanish right now. So ahora quisiera presentar a nuestros siguientes dos panelistas.
I would like to introduce now our two next panelists, Mr. Benham from Kaiser, who is also a professor on gender health from the Veracruzana University, and also Sonia Cafe, who is a regional advisor with PAHO. Doctor from Kaiser, I give you the floor. Dr. De Kaiser, you have the floor.
Gracias. Thank you very much. Good morning and good afternoon in Europe. Voy a presentar en español with the slides.
I will be presenting in Spanish with the slides in English. Here we see three men on the cover page of the document that a large group produced with PAHO and the civil society in 2013, 2022. And this is report on the masculinities, and also what we see, the rural aspects, the classes they belong to, the stratum. So it is clear that in 2021, gender is not in the genes, is in the culture, and it is in the socialization processes where we include these mandates up to a level that they become, or they are seem to be natural, and this becomes part of the educational processes, formal and informal, pressure and limits, and women are also suffering this, and also different limits that women are seeing in different ways. So our colleague from Promundo implemented a metaphor that is the box of masculinity, that is the box of chauvinism, and that includes all of these mandates, that is to say, self-sufficiency. I do not ask for help, whether I am lost in town or whether I need help, mental health, help, competitiveness, aggressiveness, and also fighting as an immediate response, physical attractiveness, physical strength, but not exaggerated so that I do not look like metrosexual, rigid goals, rigid roles that have been inherited for centuries, where compensated work is prioritized, and many women are left behind or have dual work at home and outside the home. Heterosexuality, that in itself is part of sexual diversity, but again, emphasized by homophobia, and in Latin America, this is tremendous. This is incredible. Hypersexuality, a man never misses the opportunity to have sex that is a true man, and oftentimes unprotected sex, and also aggression and control. And here the word is violence. Control, because the aggression is this capacity, this animal capacity to be able to attack, but violence is specifically human. It has to do with power, violence against women and violence among men. So men continue to have privileges, economic privileges, privileges also at the level of the economic structures nationally and also domestically, and this has enormous consequences for women. But it is also interesting because this is a window to observe the consequences in men and in others, in men and in ourselves. And here I am inspired in the violent triad that Michael Goldman created some years ago now. The study was striking to show that, and here we have binary situations. We do not see systematically other types of identity. Men and women die similarly in the Americas after 50 years of age due to diabetes, heart problems, or strokes. And here we highlight those causes that show higher contrast with women, more differences. We see violent causes, which are quite prevalent and concerning in Latin America. As I said at the beginning, and also at the peak of the teen years, this is where we see the biggest difference with women, because we start to see homicides, violent causes, accidents, traffic accidents, suicides, and up to the bottom, drowning, and also the exposure to mechanical forces. And this has to do with more dangerous jobs in the societies that are in the hands of men. 3 leading death causes linked to the use of substances, half of them related to liver cirrhosis, the use of prohibited drugs, and alcohol, which is the most widely permitted drug with vast consequences. And then we see HIV, which continues to be prevalent. So this goes from 67 to 88, almost 88% of the mortality. And at the time that we conducted this study, there was a life expectancy that was 5.8 year difference between men and women. But if we look at the orange column, there we see also the presence of men in homicides, femicides in the continent. It is quite strange for a man to kill another woman, for a woman to kill another woman, and it is strange for a woman to kill a man. And more than 22,000 cases are perpetrated by the so-called intimate partner. So we looked at details as to who was driving when more than 38,000 women die in the hemisphere a year. And the few data we found is that there is a prevalence of one male driver, but that piece of data is not systematically recorded. If we look at this throughout the life course, at the bottom, you can see the age groups. Close to 10 years of age, we start to see a complication of the causes that have to do with accidents, interpersonal violence. And this trend and the presence of violent deaths is maintained up to 50 years of age. And we see here also the inclusion of liver cirrhosis and HIV as death causes. And then they tend to become more similar to the female pattern. And also the years of, precious years of life lost are incredible. So if we have a cross-cutting view, we know that this does not happen and that these vulnerabilities do not happen identically among all men. So the social class, we can talk about poverty, but it is the social class. Being migrant, being young is a risk in many countries in Latin America, Mexico, El Salvador, Brazil, Honduras. Being native, and also hidden mortalities and the lack of self-care, the lack of care, and also not looking out for care, being heterosexual, risk practices that lead to early deaths, premature deaths, as well as unemployment. All of that has a very strong impact on this box of masculinity. Here we see the presence of the social determinant of health, and we have seen that this is a determinant not only for men, but also for women and children. As to the social response, it is obvious that if I go out to party tomorrow, the day after, or I become intoxicated, I will receive help. We do have programs in our countries that help people with problems with alcohol, HIV, or that have suicidal thoughts, but all of this is disaggregated. There is no gender outlook, and we have seen that there are programs, but many of them are marginal, they are insufficient. And there is one exception that is almost more than 10 years old, and that is the National Policy or Program for the Comprehensive Care of Male Health in Brazil. This sign says, doesn't matter what type of man you are, strong, Western, Eastern, angry, happy, be the type of man that takes care of his health. And they have also moved on to the prenatal male health. So whenever I go with my partner who is pregnant, I am also examined, and I think that they are looking into what Scotland and Ireland are doing, because they are the ones heading these initiatives, leading these initiatives. In our report, we were unable to include this inverted iceberg, what we see and what we do not see. And as Peter Baker said, it is hidden in full sight, but this is a problem in which we do not express all of these problems. I am going to mention some of them. All of the hate crimes and all of the non-compensated types of care, and also the budgets for public health, social consequences, the number of men that are homeless or in prison, and also the absent fathers. These are problems that are disseminated, they are separated, but this is also hidden in plain view, in full view. So to conclude, the recommendations of our report indicate that we need to act at different levels. The health sector in general receives the consequences of this gender education, and in connection with this powerful masculinity and the issue of power and prevalence. So we need to focus on the social media, the media in general, those that work with laws and institutions to move from a cross-cutting view of the vulnerabilities to working with different sectors from the point of view of genders for men and women, and also based on the various sexual identities. Public health is quite concerned in addressing the causes of the disease and also in trying to prevent. We have here the issue of COVID to try to, what I'm saying here is not to see men as the victims of the 21st century, but what we can do collectively and separately. We need to find spaces where men are taking care of themselves and they're taking care of the health of others. And as long as we take care of our own health, we will also put an end to other inequalities and violence. If we take care of our own health, this will also help take care of the other men and women. Thank you very much. Thank you. Thank you very much for the presentation. Now I would like to...
who is going to present the report on men's health and masculinities in the Caribbean. Sonia, the floor is yours. We can't hear you, Sonia.
Can you hear me now?
Yes, now it's fine.
Excellent. Thank you very much. And I would like to thank and acknowledge the previous speakers who have already highlighted many of the items that I will be touching on in my presentation. It's an honor and a pleasure to share this platform with you. So what I will present is a summary of a report that we are finalizing on men's health and masculinities in the Caribbean. And the reason why PAHO chose, together with other partners, to embark on the development of a Caribbean-specific document are similar to reasons that were mentioned before by the PAHO Deputy Director, by Peter, by the Minister of Health, Guyana, that there is a growing interest in the health of men and boys and in the implications of masculinities. Beyond that, we felt it was important to do a more detailed analysis of the situation in the Caribbean, because that pattern of excess mortality and morbidity and risk factors, we also see that in the Caribbean. And so the Caribbean report that we are finalizing and that we will hopefully publish in the next few weeks, the purpose is to provide a more detailed analysis of men's health and masculinities in the Caribbean subregion, highlighting the Caribbean-specific issues and trends. And of course, our ultimate goal is to stimulate further discussion and to mobilize action, strategic action, to improve the health and well-being of men women, and children, and to contribute to achievements of the Sustainable Development Goals for all men, women, and children across the life course in the Caribbean and in the region of the Americas. The methodology for development of the Caribbean report included a literature review. There is really a richness of literature available from Caribbean scholars on the topic of masculinities and men's health, analysis of health data, expert review interviews, and also data was collected from 8 Caribbean countries, including Guyana, to get a good sense of what is happening in terms of programs and policies. And so if we start with looking at the data, we see very similar patterns as what was mentioned by Benno. We see that there are excess deaths and also increased risk of death of men in the Caribbean related to preventable causes such as road injuries and interpersonal violence. This graph provides an overview of the status of the risk of dying, really, if we look at men of all ages. And men of all, if we look at this, all the ages, we see that men have almost 5 times greater risk to die from road injuries, and also the likelihood to die from interpersonal violence or homicides is also almost 5 times greater among men. If we narrow it down a little bit, looking at younger men in the age group 15 to 34, then the differences become even more marked. We see that when it comes to interpersonal violence or homicides, the young males, again, have a 4.5 greater risk of dying, road injuries, self-harm almost twice, and what was also mentioned by Benno, the exposure to mechanical forces, almost 7 times greater risk, which is related to the types of employment, the types of work that males do. If we look at life expectancy, persistently, we also see this pattern that between 3 and 5 years differences between males and females when it comes to life expectancy at birth and life expectancy at age 60. And I don't have the images for healthy life expectancy, but we do see the same patterns when it comes to healthy life expectancy. Men have a lower and a shorter expected lifespan and a lower expected healthy lifespan. So what are some of the characteristics of Caribbean masculinities that we have identified in the literature review and the data collection, speaking with experts? Of course, there are similarities with other subregions, but there are nuances that are created by the Caribbean's history of slavery, indentureship, colonialism, and the racial ethnic composition of the region. And so it will always be important, and I'm advancing on the recommendations, it will always be important to study whatever evidence is generated globally and in the region, to study it and see how it, what the nuances for the Caribbean subregion. What are some of the key characteristics that I would like to highlight here? First of all, if you know the racial ethnic composition in the Caribbean, we know that we don't have a white majority, but we do have a racial ethnic hierarchy based on skin color and political power dynamics, because in the history of the Caribbean, politics have been strongly linked with race and ethnicity, and that continues to have an effect. Also, we see that males are dominant. They dominate public spaces, and here we speak about political leadership, judiciary, workplaces, and even though males underperform in education, the data indicates that in the Caribbean, men are more likely to be employed. And when they are employed, they do earn more. There are averages of between 20 to 30 cents more on the dollar compared with females in the same employment. Social status is very important, and that's something that we have perhaps in the Caribbean in common with what Benno was presenting. Power and control are characteristics of Caribbean masculinity, and those are gained through social class, education, and if it's not possible to gain that power and control through social class or education or social class, then aggression and risk-taking and violence take the place to gain that social status that is so important and such an important characteristic in Caribbean masculinities. Hypersexuality and heterosexism are also very evident in the Caribbean masculinity, and especially hegemonic, the dominant masculinities, a very strong rejection of homosexuality. And what was interesting is that this rejection of homosexuality is shared between men and women, as several studies have documented. And that hypersexuality and heterosexism drives the need to have multiple sexual partners to demonstrate that they're real men, sexual aggression, and concealing same-sex behaviors. In those working in the area of HIV in the Caribbean are very, very familiar with this phenomenon of men on the down low, of the men who are trying to conceal their sexual orientation and their same-sex behaviors to not put in jeopardy their reputation and their status as a real man. The underperformance in education is a very important characteristic that is very long-standing. More than 20 years ago, there are articles, there are scholars who began to sound the alarm of underperformance in education on all levels of the Caribbean male. We know that it's a global phenomenon, and it was expressed in the UNESCO global report published this year, but it is a long-standing problem in the Caribbean community that affects health and well-being. Another characteristic is the absent father, which is more prevalent in the Afro-Caribbean communities. The Caribbean has one of the highest estimated rates of female-headed households. And on the other hand, the dominant father in the Indian Caribbean societies or groups with values that are inherited from the Indian ethnicity and cultural heritage, and limited ability to express bond, to express love, to express connection. And about these last three, if you read all the articles, there's a lot of debate because some scholars argue that this is very unfair because the Caribbean fathers do love their children and they do take care of their children. But here we are, and of course the values, dominant values that that are expressed in the Indian Caribbean culture are also changing. So there's also this recognition of evolving masculinities. And so when we try to address masculinities and men's health, we have to review the origins, and we have to review how they have evolved. What about men's health in services, men's health services and programs? It was already mentioned, limited engagement. Men are less socialized to promote and to maintain their own health. We also see that very much reflected in the Caribbean context. But we also see, on the other hand, some promising signs that there is a growing number of men's health programs and initiatives. Minister Anthony mentioned Guyana's efforts. We have documented efforts from the Bahamas, from other Caribbean countries that are beginning to develop men's health initiatives, programs, and services. But so far, according to the review, they are mostly ad hoc. There are some that are structural, but mostly ad hoc, ranging from dedicated services and programs to initiatives like the Men's Health Week, where there might be fairs and special events. But they're not structural and at scale. And there is no clarity on the incorporation of masculinities, the mainstreaming of gender in these efforts, these initiatives. And there's also no clarity on strategies to reach the marginalized males, as we mentioned, marginalized, sexually marginalized, socially marginalized males that really is a threat to their masculinities. In fact, some strategies actually play on the dominant masculinities to try and reach males, which further marginalizes males in situations of vulnerability. The areas that are addressed are often limited: sexual reproductive health, partner violence, responsible fatherhood, even though some countries did mention that they do address NCDs, NCD risk factors, prostate cancer, etc. Mostly in the countries, the literature and the countries that we engaged with, these efforts are led by ministries of health, but there are some partnerships with education and with civil society in the Caribbean. What we have also noticed that there is very limited monitoring and evaluation to really document what the results are of these efforts. We have also seen that the NGOs and development partners who are active, but it is important to harmonize and to collaborate the efforts between NGOs, development partners, and governments to maximize their outputs. So I will close with 4 key recommendations that came out of the analysis that was done in the Caribbean. First of all, we have to clear the path for the building of new masculinities theories and men's health programs. We have to make masculinities more visible, both the good and the bad, and masculinities as social constructs and not as inevitability, and also recognizing and inviting discussion to see how masculinities in the Caribbean can evolve to become more supportive of the health and well-being of both men and women. There is really a need to fill the gap in policies and programs. The minister mentioned that, and I think that has to be a strong push to review policies and programs and ensure that where they silence males and where they disenfranchise males, that they are corrected and that new policies and programs are developed that will really respond to foster healthier masculinities and address the needs of men. Health services need to be transformed. They need to take into account masculinities and use evidence-based or promising interventions to really transform services that respond to their needs. We have to do further research in the barriers that men face beyond commonalities and stereotypes to analyze the real barriers that men face to care so we can address them systematically. And of course, the need for further research in different areas, join forces to conduct further research that can inform strategic actions to improve the health and well-being of men in the Caribbean, addressing masculinities as social determinants of health that intersect with other determinants and that either echo these inequalities, or that can help improve the health and well-being of all men. I would like to acknowledge all the different stakeholders who contributed to the report, and we really look forward to sharing this report and using it as a tool to promote further discourse and further strategic actions. Thank you very much for your attention.
Thank you so much, Sonia. Excellent presentation, and looking forward to see the report published very soon. So I am sure you and Benno will have a lot of questions from the audience during the discussion, and especially about the concerning figures you presented and what else can be done and how to change that. So now I would like to leave the moderation to the next segment of the webinar to my colleagues, Jessie Should-Ain from PAHO and Professor Derek Griffith from Georgetown University. Jessie and Derek, the floor is yours.
Great. Thank you so much, Carolina. And thank you, Benno and Sonia, for two very interesting presentations, a lot of rich data, some recommendations. As we're now moving into the next session on lessons learned, and we will hear from two colleagues and presentations from the European region. It's always interesting and useful to hear what our colleagues in other regions are doing, and we'll have two presentations, one from the WHO European Regional Office and the other from an NGO. So I'm pleased to welcome our first speaker, Isabel Jorday, who is my counterpart in the WHO office in Euro, and she leads the Gender and Health Program in the WHO Regional Office for Europe, working with 53 member states in the European region. Over to you, Isabel. And thank you for being with us this morning.
Thank you, Jessie. Good morning, buenos días y buenas tardes.
Good morning and good afternoon to one and all.
I'm going to make my presentation in English, if that's okay with you. If you bear with me 1 second, I will share it. I would also like to say hello, not only to my colleagues, but to Noel and Peter, with whom I have been working in developing the European strategy. And first, can you see my, yes, I'm gonna put it on a slideshow. Can you see my presentation?
Yes, we can.
Yes, we're seeing it.
Okay, thank you. So I wanted, my colleagues invited me to present the work that we did in the European region. And just to tell you that the European region sometimes is bigger of what we had in mind, and is not as diverse, but it's as the Americas region is, but I think it has a big spectrum of countries. So we go from the western part, from the country I come from, Spain, although we have Portugal more to the west, and to all the eastern part of the region on the border with China, everything that is the Central Asian Republic. So when we do a strategy for our region, it needs to accommodate this complexity and variety. Peter asked me to share our experience developing the strategy for the health and well-being of men that we took to our regional committee, our governing body of 53 member states, ministers of health, in 2018. So why did we have this strategy, how we developed it, what are the principles, the main issues, and what have we learned? First of all, to say that the men's health strategy came as part of a package of gender responsive health policy. We did take first the strategy on women's health to the regional committee in 2016. And already when we were finishing the strategy and the evidence report, during the consultation process, we also had many requests to have another one focusing on a gender approach to men's health. So we did. And I think that one of the parts that I like best of the work we did was the overall consultation process. I think we work quite close with civil society, and Noel was accompanying us and Peter all the way through on trying to identify also and get the rich experience and knowledge of what it is that we wanted to put into the strategy, because I mean, we had to prioritize and use the right approach. So we had a series of consultations, both in countries, from the eastern part of the region in Almaty to the Regions for Health in Switzerland, Sweden. So including as much diversity as we could do, and of course also in Ireland. And we presented the strategy in 2018 in the regional committee that took place in Rome. And it was endorsed with a resolution. And now with next year in the regional committee on 73, we are going to do the evaluation or the lessons learned for both the women's and men's health strategy, because we do consider them complementary in terms of how to use a gender approach. Of course, I mean, as many of WHO strategies and using a public health approach, data was driving the agenda. And two of the key data that drove our agenda, it's something not very different of what was presented also for the cases in the Caribbean. But at that time, what was very striking, of course, you have the life expectancy comparison with women, but we saw, I mean, more than 10 years also of differences in life expectancy between men living in one part of the region and men living in another part of the region. And we knew also that the improvements that have happened in the last 16 years, and you have there in 2000 and 2016, were not great. So that was one of the issues we looked at. And we also knew that these are average comparisons, but if we were looking into in-country differences, we will find them as striking as when we look across countries. The other data that was also on the agenda, and it was also because at that time, non-communicable diseases was one of the main priorities of the European region, was also the difference that you see on the right figure, where we have the probability of dying for men before 69. So the probability, the so-called premature mortality. And if you look at the triangle that increases at the end, is that while if you look at respiratory diseases and cancers, there are no huge differences between East and West. When you look at the cardiovascular diseases, this was considerable. So in fact, in some countries of the region, we had 1 out of 3 men that will be dying for premature mortality because of cardiovascular diseases. So we did collect all the evidence on the report on men's health, and we were looking at different areas. We were looking at the governance. What do? We were looking at the responses of the health systems. We're looking also at the intersectionalities. I have to apologize because the website that you have there, the link, actually we are transitioning to a new website and most of the documents are not uploaded. So I did check before starting, and neither the women's or the men's health report are still uploaded, but they will be, and otherwise I can share them on a PDF file. So we have this report, and we were doing the report and the strategy at the same time in terms of the consultation. What were the key issues that we wanted to look at the evidence, and what were the key issues that we wanted to include in the recommendations? So the process of developing, compiling the evidence went in parallel to the process of consulting member states, academia, civil society on what would be the main priorities. So these are the principles that are actually gathering into the goal. And I think that for us was important to have that this should be evidence informed. the improvement of men's health and well-being, that it should be gender responsive and equity driven, and it should be transformative. So we wanted to have this also as everything, the exposure to risk and act as everything that acts as a barrier to gender equality and health equity. We were very much grounded on the Sustainable Development Goals. And I think that probably you are familiar with what we meant with gender responsive and gender transformative. And this is the scale that WHO uses for what we call the gender that it is in our gender mainstreaming for health managers tool, and it's called the GRASS, the Gender Responsive Assessment Scale. And so we wanted, our aim goal was going to gender specific and gender transformative. These are the three objectives that we had. So on the one hand, we were working using a gender approach as an accelerator to reduce the mortality of men from non-communicable diseases and unintentional injuries, as they reflected in SDG 3. We also have gender equality SDG 5 as a goal, and it was very important throughout the discussion to have gender equality as a goal also, one by engaging men in self-care, in fatherhood, in unpaid care, and in preventing violence against women and improving sexual and reproductive health. And we saw that because, and we have evidence from some countries in the region where it says that gender equality is not only beneficial for women, but it's also beneficial for men's health. And then the third one is about reducing inequalities overall across the region. And so we wanted to ensure that we could reduce inequalities between men of all ages across the region and within countries. Some of the issues that we highlighted it was the policy coherence. We wanted to emphasize that gender is also a determinant of men's health, and that men needed to pay attention within gender policies. So there is part of gender policies looking at discrimination and gender equality issues having an impact on women, but gender as a determinant of health was largely invisible. We were very keen on having the life course approach and how to make emphasis on early child development and how positive and healthy gender norms need to start there. Leave no one behind, and using an intersectionalities approach, including men experiencing multiple vulnerabilities from gender identity, migrant status, disability. It was a big entry point and tool in countries where there may be a resistance to either masculinities or a gender approach. Using the evidence and putting it forward was one of the main tools we had, and we are investing on strengthening that evidence. We also wanted to avoid competing agendas, and we have put the men's and the women's health under an overall and complementary strategy, and also member states asked us in 2018 to do the reporting and the evaluation together. Important highlighting difference among men between and within countries, and using an intersectionalities approach, and even countries that have very high life expectancy and overall indicators which are positive for men and women's health, highlighting difference within countries was very powerful. We tried to build into current priorities, and these are the current priorities now. So we don't create a parallel masculinities, men's health or women's health agenda, but we strengthen that whatever are the priorities in the European region, the gender approach, men's health, masculinities, and women's health and femininities are well grounded. So we are focusing now on mental health, digital health, primary health care, and I didn't put there also long-term care. We also continue to work on the gender equality agenda, and that we do very much through the care part, the gender transformative care patterns, and we want to highlight the violence prevention. I already mentioned the transitions, but we also I also find that there is a need to strengthen programmatic areas that do focus somehow on men, but they don't use a gender or masculinities approach, such as HIV/TB, prisoners, violence and injuries prevention. So I think that we have an untapped source there. And this is another area we need to work further. And thank you very much. I think that Noel will continue. And hi, Noel, good to see you.
Isabel.
Wonderful, thank you, Ms. Jorday Aguirre. Really appreciate your presentation. Next up, we have Dr. Noel Richardson, certainly an expert in the area of mental health research, policy, and advocacy. He's the principal author of the first ever national mental health policy, which was published in Ireland in 2009, and then the follow-up Men's Action Plan, National Men's Action Plan, published in 2016. As Isabel said, he's been a policy advisor for WHO and various other initiatives, both across the globe and certainly in the European region. And he's a board member of the Men's Health Forum in Ireland and a member of Global Action on Men's Health. So I could go on about his various accolades, but we should just go ahead and hear from Dr. Richardson. So thank you so much.
Thank you, Derek, for those kind words, and lovely to see some familiar faces here today, and to see such a high number of participants on the webinar. I'm really pleased to share with you today Ireland's experience of developing a national mental health policy and give a kind of a context, a background to that policy. But in particular, I'd like to share with you as well the key lessons learned in transitioning from policy development to implementation. So I'm not going to speak about the kind of rationale for developing a policy. I think Isabel has covered that in really good detail in relation to the EU strategy. And essentially the same momentum factors were evident in Ireland. So I'm going to focus more on the nuts and bolts of developing the policy and what kind of lessons other jurisdictions might take from Ireland's experience. So this gives you a sense of the kind of the key timelines and in chronological order and the key milestones in terms of developing the policy. I'm not going to dwell on all of these, but I think a couple are worth mentioning in particular. The first is really important, the fact that men's health was identified as a priority goal in our national health strategy in 2001. And this reflects a lot of work that went on in the preceding 10 years, both from top-down ministry and statutory service personnel, but also from bottom-up civil society members who kept canvassing and advocating and lobbying for an increased focus on men's health. So this pressure, this advocacy eventually led to the naming of men's health on a national health strategy. I'd also point to the consultation process. And Isabel has already talked about the importance of consultation in the EU strategy, but this was hugely important in the Irish context, not alone in terms of canvassing people's opinions and priorities in relation to what a men's health policy should look like, but more importantly in terms of building relationships, building collaborations and partnerships, which were the cornerstone on which policy implementation was based afterwards. So that consultation process, which included a very lengthy and drawn-out process, phase 4, of consulting with the lead agencies who were being tasked with implementing goals in the action plan that accompanied the policy. That included 6 government departments, many of whom didn't see men's health as a priority at all at the start. So it meant quite a lengthy process in terms of making the case, building a rationale, and also building relationships, as I said. And this was hugely important afterwards. So this gives you an idea of the timelines. So Getting Inside Men's Health was the research, special commissioned research project that informed the initial policy. The initial policy was accompanied by a 5-year action plan that went for external review in 2014. And the recommendation was that a more streamlined action plan would be developed as the second action plan. So that was Healthy Ireland Men. And that has just expired recently, and we're currently reviewing the second action plan
with a view to having a third action plan by the end of this year. So the detail of the development of the policy is laid out quite coherently in these two papers, which I can share with anybody afterwards, if you would like to get more detail about the mechanics of how we went about the consultation process in particular. So what was our overall approach to policy development? Well, firstly, it was firmly integrated within existing government policy. So we weren't trying to start with a greenfield site. We were trying to link national men's health policy to other aspects of policy, both within and beyond the health sector. It identified clear accountability and leadership tasks. So we had a very detailed action plan that accompanied the first policy, over 100 actions, and each action was accompanied by a lead agency who was responsible for implementing that action. Placed a firm focus on the gender nature of key men's health issues, such as alcohol, obesity, and mental health. And over time, I think we've moved from a gender-sensitive approach to a more gender-responsive and gender-transformative approach. Sorry about that. It also adopted the social determinants perspective with a focus on health inequities. So we were in particular focused on more marginalized groups of men and disadvantaged groups of men. Targeted interventions both on individual and population level. Incorporated a community development approach, particularly in terms of building relationships with NGOs and leaders that would provide access to more marginalized groups. It adopted a strengths perspective. So it wasn't about naming and shaming men. It was about working from a strengths-based, salutogenic approach to masculinities. And it focused on prevention and supporting men to become more active agents and advocates for their own health. In terms of governance, because I think this is really important when it comes to policy implementation, the policy was overseen by a national implementation group that was co-chaired by the Department of Health and a health service executive member. There was an annual plan and a progress report at the end of each year. There was an attempt to align the policy with other policy priority areas. As I mentioned earlier, it went for external review at the end of 5 years, and the second action plan is currently being reviewed externally. There was an annual communication strategy, which was about profiling and highlighting key men's health issues for that year, and in particular around Men's Health Week, to create awareness around men's health issues. There were explicit links to a gender mainstreaming framework and working with women's health. Evaluation, research, and knowledge translation was a key pillar of the policy, and 2 research centres in particular became very proactive in terms of aligning with NGOs and statutory organisations and bringing in an applied or action research approach to a broad range of men's health initiatives. And there was some cross-departmental work, but overall that was challenging, but some inroads being made. If we just highlight one example here, the Department of Agriculture was one department we consulted with originally, and we made very little progress in the first iteration of the action plan. But more recently, we've got 2 national programs that are working with the Department of Agriculture. One is a cardiovascular disease prevention program, working with farmers in workplace settings. And the other is a training program, training agricultural advisors to act as health connectors with farmers. So there were programs that didn't get off the ground immediately, but it's an example of where patience and building relationships and, over time that can lead to positive outcomes in the longer run. So the review of the original policy that Peter actually did recommended a dedicated national focus on men's health in Ireland. But it also recommended the development of a revised, more focused action plan for men's health that would support the effective implementation of Healthy Ireland. So the original action plan was very ambitious, over 100 actions, most of which weren't achieved at the end of the 5 years, I should acknowledge. So the recommendation was clearly to have a more kind of honed action plan that would align with the key priorities of our national health strategy, Healthy Ireland. So this is the second action plan that's just finished and is currently under review. So given the time, I'm just going to run through a couple of examples of some of the key successes of the policy. The first is the links, as I mentioned earlier, between research and knowledge translation and the development of toolkits, training programs, and resources, many of which were linked to national men's health programs, like Sheds for Life, a health promotion program for men in sheds, Men on the Move, a physical activity program targeting inactive men, and Farmers of Hearts, a cardiovascular disease prevention program targeted men in Marts, and more recently, Corda, which is a program targeting suicide prevention in the construction sector. So these are all examples of programs that are either in the process or have been scaled up to national programs. And the key point I'm trying to make here is that they wouldn't have been possible without close collaboration between academia, NGO, civil society organizations, and statutory health services. And that's led to a really productive and varied program of research activity. Training has been a critical element of in terms of developing capacity among service providers, and engaged our national men's health training program that has been on the go now for over 10 years. Initially, it started out as a generic training program to equip service providers with the skills and competencies to more effectively engage men. But over time, new modules have been added, such as focus on young men, middle-aged men, and more recently with a focus on training agricultural advisors to engage more effectively with farmers around health. Men's Health Week has been a huge factor in our national men's health policy. This is coordinated by the Men's Health Forum in Ireland with over 100 partners, and it's had a key role in raising awareness and raising the profile of men's health in Ireland. Okay, so in terms of key lessons learned, so I've kind of synopsized these into 2 slides. Identifying men as a target population group at a national health policy level, proper fastening the political will to prioritise men's health. So having men named in a national health strategy originally provided an important kind of rationale and momentum to go ahead and develop the policy. Because just before the policy was launched, it coincided with a really big recession in Ireland. And I think there is a real danger that the policy might never have got published if it wasn't for the fact that there was a commitment in our health strategy to develop and launch a strategy, national policy. The consultation process, as I mentioned, not just informed policy development, but underpinned the partnership model that was the cornerstone of policy implementation. So I can't emphasize this point enough. The relationship building, the partnership and collaboration that was the cornerstone of the consultation process really stood us in good stead in the longer run. The need for transparency in managing expectation and signposting policy decision-making, that's really important because policy can only reach so far. And as we discovered, the first 5-year action plan was far too ambitious given the resources we had to implement it. So you can't be all things to all people. So there is a need to prioritize and to agree timelines for actions. And there needs to be transparency in that process so that everyone is aware of the decision-making underpinning the prioritizing of some areas over others. The importance of having strong governance and accountability measures in place to maintain a focus on men's health. Policy is only as effective as the governance and implementation structures that are there to oversee its implementation. Without those, policy can't be effective. The importance of leadership and advocacy in getting and sustaining men's health in a policy agenda. Again, I would stress the importance of top-down leadership as well as bottom-up leadership. So we had some key allies in the Department of Health and in the statutory health services who maintained a momentum on men's health, as well as the advocacy groups I mentioned earlier, like the Men's Health Forum in Ireland and the Men's Development Network. So that top-down, bottom-up approach is really important. Partnership has been a key element, as I mentioned. The highly significant role that Engage played in building capacity to support policy implementation. So that didn't just equip participants with the skills to engage men. It was also designed to change culture within organizations and to get more focus on men's health. the importance of balancing ideological versus pragmatic approaches to men's health. So the first action plan was broad and aspirational, but it did set out our stall in terms of what was important. The second was more pragmatic. Growing the evidence base through research is really important. Approaching other sectors on a win-win basis. Patience is really important. Having communication strategy and profiling success is really important. Using the policies as an implementation tool for a national health strategy is important. And excellent relations with women's health, but gender mainstreaming is a limited impact. Conscious of time, so last slide, key take-home message. I would advocate that there is a really value in having a men's health policy. It identifies men's health as a priority area. It creates a vision, identity, and branding for men's health. It provides a framework for action and a roadmap for practitioners. It gives leverage to expanding men's health work because it's underpinned by a policy. It supports intersectional and gender transformative approaches to service and program delivery. And it offers an opportunity to apply a gender lens to other policy agendas. So sorry for rushing there, but that's it. Thank you very much.
Great, thank you so much, Dr. Richardson, for that, very practical and useful presentation. We are now moving into a discussion session. And so I know we have some questions on the chat. We have about 10 minutes and many of you online. So what we encourage, and I think this has come up from some of the participants too, if you could please share your comments on the chat and any questions as well. We'll do our best to try to read out as much as possible and see and field some of the questions. We've had a lot of rich discussions and learning today from learning more about the context around masculinities, the determinants, policy, the data and information that is just coming out now from the Caribbean. And we've got examples from different parts of the world. So there is one question that came up early on that was about disabilities. And I'd like to direct that to Dr. Sonia Cafe about the research that was done and if it included men with disabilities.
Yes, thank you. This is a very important question. We tried in our review of evidence and of articles to look at different vulnerabilities and marginalizations in different sectors. And so, yes, we did identify issues related to men with disabilities as, again, an added layer of marginalization and vulnerability that has to be taken into account.
Great, thank you. We had another question here, and you know, we don't, unfortunately, we don't have a whole lot of time. But there's a question, teniendo en cuenta que el propio sistema de salud reproduce las normas rígidas de género, quería saber si había experiencia.
Taking into account some of the rigid standards that we have in some of these countries, has there been any work with the other universities and countries to try to include this topic in the curricula of universities and colleges?
And I was thinking that we could direct that question to Benno.
Mm-hmm. Yes, gracias, Juan Carlos. Tú y yo sabemos.
I thank you, Juan Carlos. You and I know that the problems that have to do with gender in the area of health itself, I think, have not been properly addressed. Doctors, nurses, the power relationships that we have in the health sector, as well as the narrow gender view, not only outlook, not only regarding gender policies, but also on the daily relationship among children and women and men that approach the health services. This is something that is quite divided along the lines of biology and still with the maternal child focus. That is a great challenge, and from there we jump on to training at the level of universities and also the training of health professionals in internships and also in various residencies and programs are issues of harassment that have been silenced for a long time now. I think that you are pointing out to this need, and I am cooperating with the National Autonomous University of Mexico, and we're trying to show all the experience that we have in the area of gender, but also in the area of masculinities, and trying to convey this to the authorities, to the universities, to students, and also building strategies, multiple strategies that are geared to avoiding violence and attaining equality, gender equality. This is quite new. We include comprehensive work with men, and we are implementing this with a community and preventive outlook to avoid violence, prevent violence.
Thank you. So we're going to take one last quick question and then close. This question I'll pose to Sonia, Dr. Kefe, if you don't mind. There's a question about, besides Brazil, what countries in the Americas are working on adopting national level men's health policies, and which countries are closest to implementation, and what we can do to help these efforts get to the line. I think Benno actually, but between the two of you, may be able to speak to that question quickly, and then we'll close as well.
Thank you, and Sonia is fine. So we have seen this clear commitment in the PAHO member states have insisted on an indicator on men's health in the PAHO strategic plan. And when we say PAHO strategic plan, it's not a plan from PAHO as an institute, but PAHO, the American community. And so they have insisted on an indicator on men's health, and they have given us as Secretariat the task to develop policy guidance on men's health. So there is a clearly defined commitment in our region that is growing. When we look at which countries have developed policies and plans in the Caribbean, specifically, as the minister mentioned, Guyana has developed a men's health plan or strategy. The Bahamas have developed. I know that in some of the Latin American countries, there are some countries that have developed plans of action or specific actions articulated in policies or programs for men's health. And some have indicated that they are currently developing. We are actually planning to update our inventory of where countries are at this time. I cannot mention the numbers, but I know that there is a growing number of countries that are developing or that have recently developed men's health strategies or policies or plans.
Thank you. Benno, did you have anything to add before we close? You're muted.
Sorry. Creo que bajo estas tremendas estadísticas que presentamos para América Latina y también se presentan para Europa.
I think that these incredible statistics that we are seeing for Europe and Latin America, we see the importance of mental health, the dimension of mental health. When we look at addiction, suicide, and homicides, they are crying out for help. And the issue, and in particular, the issue of mental health, we need to move away from biology and start looking into psychiatry to look into a broader mental health and even a more positive mental health from the point of view of the management of emotions. And also by reading the questions, this vision is not possible just moving from family planning to a more comprehensive outlook that includes sexual rights, reproductive rights, and also the rights that are being threatened not only in the US, but in other countries of Latin America. Costa Rica already has a national health policy. There is a national center on reproductive health and gender equality. And Juan Carlos, we have also been working in Argentina.
E hijas como un elemento de salud reproductiva importantísimo. Gracias.
Gracias. So to close, I want to give the last bit of the floor to Dr. Vega. Thank you for being patient and apologize. We're running a bit behind. Dr. Vega is the Regional Advisor on Aging and Health and the current Unit Chief for the Healthy Life Course Unit, PAHO. He's also a Professor of Gerontology and Geriatrics at Medical University of Havana, where he's been for about 30 years now. So thank you. The floor is yours.
Muchas gracias por la presentación. Muchas gracias a los panelistas por
Thank you very much for the presentation, and I also thank the panelists, and thank you very much for these presentations.
Sobre el tema de salud de los hombres.
Certainly the question of men's health and masculinity is very important. And it's very clear from the panel that we have the necessary evidence that this is something we need to work on. We also have sufficient experience in order to kick off our work and to begin to intervene with specific actions. So we see what we need to learn yet, and the panelists have also indicated how we need an integrated approach, a holistic approach, not only a gender approach, but an equity approach. We also need to look at the social determinants of health, and we need to look at the life course as well and the life cycle. So these are certainly all aspects that we need to focus on to make our policies more effective. Now, it is not enough to just simply work on public policy. We need to be able to achieve and intervene clearly so that we have effective access and coverage. And we need to achieve health and development at a much higher level. So I certainly appreciate everything that's been said. I thank the WHO and PAHO, and I'm very much honored to participate. And we would be very happy to extend our collaboration and to make the work more effective so that all of these experiences bear fruit. Thank you very much. And we will soon have an evaluation of the seminar to be distributed, and a good afternoon to all.
Thank you.
Thank you. Gracias.
Gracias a todos.
Thank you, one and all.